Seth had just texted. I just sent him the meeting address. He said he's doing it from home this week, it sounds like.
Oh, yeah, it hasn't changed.
So
You got it good. Thanks. All right.
since we have a lot of people on, I think I'll just keep it to 2 cases for now. This is one I've been waiting for pathology and waiting to show for a while, and it's it turns out multiple people were right for different reasons. So this is a woman who's 49, and she has a long-standing history of what were described as recurrent pneumonias in her her right middle lobe. So this was an outside CD that she brought in. The surgeon going to take out her right middle lobe because this was thought to be chronic recurrent infection, a source of chronic recurrent infection, which, you know, maybe, but you know, what bothered me at the time was this area in her right lower lobe, you know, some of the other ground glass and cystic looking stuff in the right upper lobe, and then this nodule in the left upper lobe. I was worried this was going to be multifocal adenocarcinoma and like a cystic destructive portion of this. They had biopsied this and only gotten inflammation at an outside place. So that was 2016. A few months later, in 2017, before they take it out, you could see everything's kind of similar. So it's several months later, this stuff is all still there, making me much more worried about a multifocal adenocarcinoma. Make a long story short, they took this out. They did a right middle lobectomy, and what do you guys think they found based on this look?
Coxy?
It wasn't coxy.
Do you have a coronal? Is that round thing potentially a mycetoma looking like thing?
No, there's not a mycetoma in here. But to make a long story short, they took this out and they did find adenocarcinoma in this, and it was a mucinous adenocarcinoma, and it was arising in a type 1 CPAM. So this was all a congenital pulmonary adenomatoid malformation. So she had been having recurrent infections. However, it had been complicated by development of mucinous adenocarcinoma. Then she went on chemotherapy after this was taken out for the presumption of this being multifocal adenocarcinoma. And none of these areas really ever changed that much. And so we did a CT guided biopsy of the right lower lobe. It confirmed adenocarcinoma. They did a right lower lobectomy. It was more mucinous adenocarcinoma. And then they ended up treating this other lesion in the left upper lobe with CyberKnife. So this one they treated, with CyberKnife up here. So this is the first, I don't remember seeing a CPAM with adenocarcinoma arising in it before, but it has been reported in the literature. And I know we've shown other congenital things. I believe it was Blake that had shown like a proximal interruption of the pulmonary artery where the patient had developed adenocarcinoma throughout the lung. But this was from Journal of Thoracic Oncology. They reviewed 134 publications looking at a bunch of different congenital pulmonary malformations, as they call them all. And interestingly, even in kids, patients with abnormalities like CPAMs end up with other tumors, usually pleuropulmonary blastomas, and then in adults, it's more commonly adenocarcinoma, or, in the older literature, they reviewed bronchoalveolar cell carcinoma. So this was one where turned out we were both, everybody was right. There was recurrent infection in the right middle lobe, but the presence of the multifocal stuff made us worry for an adenocarcinoma, which was also there. So very interesting, conundrum of a case. Have you guys seen that before?
I think I've seen one in my career of that entity, adenocarcinoma, developing in an area of CPAM, presumed CPAM.
Yeah.
I think it's,
but this was,
I think it's a lot less common than it's touted to be, because only the ones with cancers get reported.
Yeah.
We see them all the time, and
of course.
Yeah. So,
right. So there's a selection bias that, yeah, nobody writes up the CPAM without the cancer in it.
I guess my question is what do you do with these things then? I mean, do you follow them forever?
Yeah, I don't know. I don't know if anyone knows. And, and it's more like the CPAM was the kind of interesting part of it, but not the biggest issue, which was the fact that this was multifocal adenocarcinoma at the time of diagnosis. And it's like, I'm sure you guys have seen other cases too, where they go in and hack out one lobe, and then you've already got stuff in other lobes, and then you can't take out lung forever when you have multifocal disease. All right, and then this one, I'll show this one really quick. So this is a guy who's 41, and he came into outside hospital with about a week of worsening fever, chills, B symptoms, and progressive respiratory failure necessitating intubation. And you can see on this, he's got relatively symmetric bilateral areas of consolidation. He got transferred to us with a clinical diagnosis of ARDS and ended up even requiring prone ventilation. So the question for us was, is this vaping-associated lung injury? The patient, his girlfriend had reported he had been vaping marijuana. He's also a heavy cocaine user and an alcoholic. But, the CT, of course, we said it could be, but we didn't know for sure. He does have lung injury. And I show this only because he's got bilateral areas of consolidation, pretty severe. This was a few days later, similar findings that weren't changing. And about this time, he developed renal failure, but his urine Legionella antigen came back as positive. And also he had a tracheal aspirate subsequent to that were both positive for Legionella pneumonia. So we had a long discussion, and the infectious disease and pulmonologist told us that the Legionella antigen is fairly specific. If it's positive, then they almost certainly have Legionella pneumonia. And so he was treated with levofloxacin, and he was treated with azithromycin, and a couple weeks later, you can see that he's still trached, but his lungs have gotten better. And so this is actually not a case of vaping-associated lung injury, but it's a case of Legionella pneumonia, with just severe pneumonia resulting in acute lung injury. And I only show that just to drive home the point. I know we've been focusing a lot on this. This is from the CDC when they talk about confirmed and possible cases. One of the most important things is that their workup for infection is negative, and especially they specifically mention Legionella in here as one of the ones. And I know now that we're getting into flu season, it's also important that the CDC have made a comment, just make sure these patients don't have influenza rather than vaping associated lung injury. So
Travis, I think that the urine antigen test is not very sensitive for some of the species of Legionella. So
no, you're right, but it was positive and it's very specific. I was told it's almost 100% specific by our infectious disease team. So yeah, when they have it, they treat it as a true positive.
Where did they figure the Legionella came from? Was it associated with an outbreak or anything?
No, and I don't know the answer to that.
In a vape pen in the water,
right? In the chamber, I don't know. So, but yeah, no, I just show that one to remind us that a lot of these cases still aren't vaping related.
Okay.
So that's it for now, Jeff. I'll let everyone else go.
All right. Who'd like to go next?
I can show two or so, and then other folks can.
So could you call me at 1 o'clock this afternoon? I'm in the middle of a conference. Okay. All right. Talk to you soon. Bye.
For this particular patient, I actually want to show you the background to the case. So take a look at that. I'll just give you a moment to read the first 3 paragraphs. So this patient came in with that history, which of course we didn't necessarily have in the beginning. And I will show you that this is just a radiograph from before. Actually, let me just show you the CT. I'll go back in time. At the time that he's ill. And you'll see there is a lesion here in the superior portion of the azigoesophageal recess. You can see its relationship to the right main bronchus. And then I'll scroll through to show you that we have a communication with airway, trachea. And I'll just go down a little bit further to give you an idea of where esophagus is. And then you can see there's a lot of pathology there. I'll switch over to mediastinal window so that you can see the proximity of this pathology to the esophagus and the trachea. And you can see there is a connection between the trachea and the esophagus and the lung. So we have a tracheoesophageal communication, fistula, and that opacity there. Now I'll go back in time to before and note on this image the location of the catheter associated with the pectoral port. And yes, it is in the azygous vein. You can see right there. So this finding, together with what we see before and the history, very consistent with a complication of that. So presumably infusing the chemotherapy through the azygous vein catheter repeatedly was complicated by the development of this process in the mediastinum and lung and the tracheoesophageal fistula. I've certainly not encountered that before, but given that history, I think there is a direct and proximate causation between those. Any of you folks seen anything like that before, or something analogous to that?
So Howard, this wasn't cancer metastatic to the mediastinum.
Nope.
All this was the only preceding thing here was the catheter placement. Is that it?
Yeah, the chemotherapy over a period of time.
Mm-hmm.
They confirmed the fistula. You can see they put in an esophageal stent as treatment of it. I think it's plausible, perhaps, that if you have a high concentration of chemo in a relatively small vessel right there, that may in some way have produced the pathology there that subsequently involved the contiguous airway and esophagus, mediastinum, plausibly.
No, that's.
I've seen extravasation, in subcutaneous from port, port needles malplaced and things like that. I've not seen it deep in the mediastinum like this. That's cool.
Yeah, it's pretty scary. I mean, we don't know what that, that is the proximate cause, but it certainly seems like that's what it might be, right? Given the location of the pathology in this catheter. Let me show you this one that's interesting. All right, so this case goes over many years. The initial CT that we had prior to a biopsy that was done shows these findings. And the very conspicuous findings are the presence of thickened interlobular septa, some of which are very thickened, and peribronchial fluid cuffs, and subpleural edema in the lungs, but mostly in the lower lobe. And the amount of fluid within the connective tissue sheaths surrounding the bronchoarterial bundles is very extensive. The lumens of the bronchi are narrowed, associated with the cuffs of fluid. So he presented at that time, that's back in 2011. Then he had a lung biopsy, I'll show you that in a moment, in which they did see abnormal vessels, and they wondered whether he actually had, by virtue of some cell surface receptors, whether he actually had a venous malformation. In particular, they didn't really specify or jump in on a lymphatic malformation so much. And they do different antibodies, and some antibodies are, or some cell surface receptors are more suggestive of a vascular etiology, and some point more towards a lymphatic etiology for the malformation. Be that as it may, he wasn't that ill, and it was quite a long time thereafter when he developed pleural fluid. And here you can see pleural fluid, and this is after the biopsy, quite a long time after the biopsy. He still has thickened interlobular septa in his lungs. And now I'll show you the nature of the fluid on thoracentesis. So he definitely developed a chylothorax. And because of these cell surface receptors, they wondered about a venous etiology. But I think the entire imaging appearance and the presence of this is very consistent with thoracic lymphangio-myomatosis. Even though I think this one over here, the D240, is one that points towards lymphatic tissue. But like anything else, things don't always work out 100%. So I think this is very definitely a case of thoracic lymphangio-myomatosis. He doesn't have bone involvement, he doesn't have splenic involvement, he doesn't have mediastinal tissue involvement. It's just lung disease. And he's had thoracenteses, and he's doing okay. He's not very ill. And now we're about 7 years out from his initial presentation. Anyone doubt that he has thoracic lymphangio-myomatosis, given the findings?
No.
It's a good fit.
It's a good fit, isn't it? Imaging-wise.
Can you guys hear me at all?
Yes.
Yeah.
Okay. Yeah, no, I've seen this a couple times, and it's a diagnosis.
Good. Okay.
I always get confused between this and like congenital lymphangioatasia.
Yeah, the pediatric lymphangioatasia.
That's more
Obviously,
severe
illness.
symptoms.
They present with a lot of lung edema, and typically in the neonatal period, I think, or in early childhood, when they typically present with lymphangioatasia. Okay, I'll show one more. Okay, just confirm this with me. I wasn't in attendance, but Jeff, did you perhaps present this case, hold on a second, on behalf of Tom? That is a vaping-related injury with cystic change in pneumothorax.
I did, yeah.
So that's pretty much what that is or was.
Yeah, I didn't see that. I wasn't on that week either.
Oh,
I only
well,
read
I
about
show it again, Howard. It's worthwhile because it's the only one I've seen progress like this.
Okay, because the dates are funny. So perhaps in the anonymization, these dates of 2015 are perhaps not correct.
Yeah, those aren't the real dates.
Okay, okay. So this case is one that you showed, and certainly billed as very extensive cystic change, obviously, and secondary pneumothorax, or pneumothorax, as a consequence of vaping-related lung injury, right, Jeff?
Yeah,
is that right?
Yeah, if you show the original scan, they were, if I remember, they were about 2 weeks apart. And so this is a classic appearance.
The initial one looked like that.
Yeah.
Okay.
And what's really interesting is that these bullae or whatever form in the periphery of the lung, away from where the injury was. And then clearly there's an air leak because you've got that sizable pneumothorax with the drain still in there.
Yeah.
Was Howard, was the guy on a ventilator, or does anybody know if he was ventilated on that initial CT? Is he ventilated? No.
No, he's not
non
ventilated,
rebreather mask.
and he's not intubated here either on that one. So I have a similar case. So here it is. So here is a person with, starting early on, radiograph showing some relatively subtle pulmonary opacities. I'll show you the first CT, which is October 9. And we have findings very consistent with vaping-associated lung injury. And there is a little pneumomediastinum, which I would ascribe presumably to the Macklin phenomenon if he was retching, vomiting, coughing, etc. And he was discharged and came back with a pneumothorax. So that is the name. He was out of hospital for, I think, just 2 days before he came back with worsening symptoms, worsening lung disease. Here is an image after chest tube placement. I saw this on a radiograph. It's confirmed on CT. So here is a solitary large cyst in the middle lobe in a patient that presumably continued to vape, and another cystic space. So that's really interesting. I don't know the etiology of this, but we seem to have 2 cases now.
Where is that relative to the minor fissure?
Okay,
Above it?
it is just beneath it, huh?
It's on the fissure.
Or is it
Yeah.
in the fish?
Yeah, I wonder if that's just
Loculated.
loculated.
Oh, no,
There.
I think it's in the lung. Yeah, no, it's close to the fissure. But I thought I had images. I didn't think that it was loculated pleural air necessarily. Well, now you're making me think, how do I know that for sure? Let me see. Here it is. Around it. Well, I certainly assumed that it was in the lung, but I see the point, because it seems to be in relation to the fissure,
Yeah, I would vote fissure personally.
intravisual air, just in the fissure. Yeah, point well taken. Maybe it isn't in the lung. There's another cystic space there, a small one though. Okay, so I'll have to put this on the back burner at least and see if we ever encounter these again. Maybe this one is rather in the pleural space rather than in the lung.
Yeah,
Let's have a look at it.
interesting. Yeah, the one I showed that you just showed us with that, how it just developed these subpleural cystic spaces.
I wonder if it's cicatricial due to the fibrosis that's developing.
Maybe. Okay.
Well, I don't know for sure. This is before that pneumothorax developed, and of course I can always read in retrospect and wonder about a cystic space, but point well taken. I may have to retract that. Okay, I'll let you know if I ever figure it out or see another case of cystic lung disease. I'll show it to you, obviously. Okay, Jeff, those are mine.
Thank you, Howard. All right. Peter, Seth.
I can go. So I'm doing this from home and I'm getting a lot of feedback. So let me know if you guys can understand me.
All good.
So this is a really cool case. I have to say I stole this from University of Maryland when I was back there lecturing in DC a couple days ago. So this is a patient who has a extensive ill-defined central lobular nodularity. You can really see sparing the subpleural surface. Lower lobes, nodules not as impressive, more ground glass, some mild mosaicism. And I think most of us would say that this is probably a hypersensitivity reaction, which this was, but this is the first case of hypersensitivity pneumonitis that I've seen from actually inhalational talc. So this was a patient who powdered her face daily with talcum powder and came in with shortness of breath and underwent lung biopsy. And let's see if I can pull this up. Unfortunately, the case isn't anonymized, so I'm hiding the name over here. Otherwise, I show some other images. But this was her lung biopsy, and you can see this material in the interstitium that is polarizable. So this was actually an inhalational talcosis, and all the talcosis I've personally seen has been intravenous. So different obviously etiology between an airway injury versus arteriolar impaction, but interesting.
I was going to ask you what organism living on the talc caused it, because it seems like talc alone is too big to incite a immune response.
Yeah, I don't know.
Isn't it like a calcium silicate or something?
But the talc was in her interstitium itself, so clearly it got there.
Yeah, it's just interesting.
So those are granulomas there, right? On that little blob of tissue with all the debris in it is a granuloma, would we say?
I don't think this is a granuloma. I mean, this is thickened alveolar walls with some presumably collapsed alveoli. That's what I would think. This doesn't look like a typical granuloma.
No, it almost
is that the airway center? Is it a cuff around the airway?
No, this isn't this is not bronchial epithelium. This is, I can get more path. This is just one area that they had downloaded. May not be representative of the hypersensitive reaction in terms of airway centered abnormality.
Okay.
Hey, Jeff.
Yes. There's a bunch of debris in those alveoli there too. Are we seeing a bunch of?
Talk to the pathologist. Unfortunately, I'll talk to Burke. This was a Maryland case, and these images were just downloaded on the PACS. So unfortunately, I don't know what all this other material is, because I agree there's a lot of debris in here with odd stuff, and I don't know if that's related to the reaction or something with fixation and something.
Yeah. So
Jeff, switch back to me really quick.
Yeah.
Sure.
Because I just pulled up an old case. I remember having one at Emory that I showed way back when, and it was a guy that used baby powder in his bathroom every day. And I remember the areas of more confluent consolidation. I was just looking at this case though now, and sure enough, it's the same thing. I mean, there's just diffuse central lobular nodules, more fuzzy ground glass everywhere else, and it's slightly more upper lobe. And some of this consolidation is higher attenuation too. Granted, it's a CT with contrast, but some of the dense stuff. So I didn't remember all of the features of this.
So Travis, if you guys go back to mine real quick, I was able, when you were on mine, or on Travis's, to show a follow-up. So she didn't stop using the talcum powder and kept using it and developed more areas of confluent consolidation, and here developed some sort of more acute lung injury or something causing this large effusion. I don't have too much history, but this was about 3 months later after the first CT I showed. So maybe kind of similar to what you showed, with more areas of nodulary becoming confluent.
So Seth, I was even wondering on that path whether there could be a little alveolar protenosis going on, because with acute silicosis, for instance, they get alveolar protenosis. Basically, there's the macrophages are helping the stuff up and spilling it.
Yeah, I don't. You're completely 100% right. I'll actually email the pathologist and see what that other stuff was.
Cool.
Goes down this case, so there's no stuff. And this is two of the cooler cases I've seen recently. This one is a patient who came in with chest pain, a young female, about 40 or so, and had a non-ST elevation MI, pretty decent troponin pump. They wanted to take her to cath. She said, I wanted a coronary CT instead, which is probably a good move. And if you look at her coronaries were very normal, except for, if you look here, look what happens to the distal LAD. So we have a relatively normal caliber vessel, coronaries are normal. And then we get to the distal LAD, and you see this dramatic narrowing and this inflammatory change surrounding the vessel. And I've seen a couple of these, and it's very similar to the other cases I've seen. Let me just, sorry, I'm not used to using this program. And where you just get this pronounced diffuse long segment narrowing. And there's a differential. It could be a vasculitis, but this patient has no other signs of vasculitis or no history of such, no other arteries anywhere involved. And this is a pretty typical appearance for a type 2 coronary dissection. So this is basically an intramural hematoma of the coronary arteries that's that inflammatory change surrounding it. And, you know, you don't want to traditionally, technically cath these. You can, but you can lead to further injury. And you can see it gets diffusely narrowed and then opens back up very distally. And this patient was treated conservatively. And fortunately, so here you can see normal and then gets all this inflammatory change around it. You know, the classic diagnosis is via cath and intravascular ultrasound to confirm that it's blood, but the imaging characteristics are pretty typical for the cases that I've seen. Yeah, no, it's fortunate that it hit the distal LAD and not the proximal LAD. Classically, these occur in younger women. It's actually the #1 cause of MI in women younger than 50. And there's a lot of literature coming out on this that we miss these a lot, not only on coronary CT, but clinically. It's a very underdiagnosed cause of myocardial infarct. So just the type 2 SCAD and show, hopefully the blood will resolve and the patient will get better.
So idiopathic spontaneous intramural.
Yeah, it's coronary dissection. So there's type 1 is where you see a true flap, which I've seen more than these. And then a type 2 is basically like an IMH.
Oh.
Then the last case is my favorite case for a long time because I was actually able to make a correct diagnosis for once. Take this off. So this was a patient, this was kind of cool for various reasons. This patient came in from the outside and was diagnosed as having peritoneal carcinomatosis because she came in, she has liver failure, she has Hep C, and she underwent CT, and there was all these little enhancing nodules everywhere. And she was diagnosed at an outside hospital with peritoneal carcinomatosis. You can see that she doesn't have a normal spleen. She has a lot of splenic tissue. She had a history of trauma. And just to show this portion, the people at our institution correctly said this is probably splenosis. They got a liver spleen scan, which showed that these soft tissue was all splenic tissue. So this is intra-abdominal splenosis. But what was interesting is that on the abdominal portion, they noticed this cystic lesion. And the cystic lesion is, put it on MPR, located right where the AV node sits. And I showed this to Jeff and Travis the other day when we were kind of sitting around because the thing was broken. And the AV node, you remember, sits right here. It's basically where the LV and the RA come together, kind of inferior to the outflow tract. So sits right in here. And there's just remembering this from reading a book some time ago that there's something called a cystic tumor of the AV node. And, you know, they were concerned because they thought this could be metastasis because of the abdominal findings, which were initially read as a malignancy or a peritneocarcinomatosis. So we did a cardiac MRI, which is kind of, if I show this. So you'll see there's this lesion sitting right here, right on the SSFP, which is an inherent kind of T2 weighting. Here it is on the T1, low signal. Here it is on the T2, similar signal to fluid. This is a longer, heavier weighted T2 sequence showing a little bit brighter. Here's the perfusion, and it shows that there's no uptake. And so this is going to be a cystic tumor of the AV node, which is a developmental cyst. And nicely you can see, to confirm it's all fluid, this is a TI of 300, which will null myocardium, but because the blood, because water is still very far off the x-axis in terms of nulling, it's still brightish here. The fluid's still bright, but when we get closer to the 600 inversion time, the cyst is darker, just due to the fact that it has a longer inversion time. So this is a cystic tumor of AV node in a patient with intra-abdominal splenosis and cirrhosis.
Very cool.
So that's funny because there was pulmonary abnormality and pleural, but all of those things are not related to this, of course. But there's some other things going on. But that's just an observation, right?
Oh, her lungs?
Because she had some
Yeah, I
radiologists
mean,
and some other.
you know,
other
she's got she had a pneumonia. This was she had. They're not really sure what happened, but she coded, and her white cell count was positive, and this has gotten better over a couple of days. But now they're in a kind of a conundrum because this is associated with sudden cardiac death due to a heart block. So they need a transplanter for her liver, but they're concerned about transplanting a patient with this benign cyst because it's just in a bad place.
So it's not a cellular thing. So tumor may not be the precise term. It's
No,
just
it's not. It's just what it's called. It used to be called even a mesothelioma of the AV node because they presumed a long time ago when they saw these that they were lined by mesothelial cells like pericardial cyst. But actually, Merck and Romani wrote a paper of like 50 of these, and they realized that they're actually, cysts are actually lined by embryologic remnants like cells that secrete AFP, CEA, and other fetal hormones, and they think it's their arrested embryologic rests of tissue that get stuck there and form a cyst. But they're just cysts, but there's nothing tumor to them.
Wow.
Okay, well, thanks.
Anyways.
All right. That is.
Yeah, that's really cool.
Who has not gone yet?
Me.
All right.
Can I show you? So I'd like to show you guys first a case with a pretty unremarkable chest radiograph, slightly low volume. This man had some respiratory distress a little bit. He was, when he exercised, so they thought his diaphragm might be weak, so he came in for diaphragm fluoro. Does have lowish lung volume that goes with that. And he's got a lot of abdominal fat, which is the usual cause of low lung volume these days. They were also concerned that he might have diaphragm dysfunction because these CT scans had identified a tumor of the diaphragm. So tumors of the diaphragm are pretty rare, and the most common is lipoma. So this is my first case of lipoma of the diaphragm. You can see that near the cruce here, there is this little fat collection in the muscle of the diaphragm. There is a rim of muscle outside it, so this isn't fat pushing in against a thin area of muscle. It's actually, this is embedded in the diaphragm muscle. This is 2014, and currently on 2019, you can see that the lipoma is bigger, but it's still very well behaved. It looks like a benign lipoma with very little tissue except homogeneous fat inside. And he's got a lot of fat elsewhere, so he's good at generating fat, and he's put a little bit into his diaphragm. So my very first case of diaphragm lipoma. So Seth, this gives me the same pleasure as your cystic tumor of the AV node. This is you know, this is a real celebration, this case. So we get off on different things. Just radiologists are pretty quirky. So then I'd like to show you a case of acupuncture needles. This is a woman with a Korean last name, and I don't remember right off what her malignancy was that required a catheter, but she is treated with these with acupuncture. And one of the styles of acupuncture is to actually break off the needles and leave them embedded in place. So sometimes, usually the needles are withdrawn. They may be stimulated by twirling or by vibrating them or by even heating them and stuff like that. In some cases, they are placed and they're broken off. The tips are broken off and left in place. And that's what we have in this. And the nice thing about this case is that there is an accompanying CT that shows you that these needles actually go into the subcutaneous fat here. So they go through the skin into the fat. They're pretty superficial. CT that further showed the subcutaneous location of these tips. So this is acupuncture, and it's we see this usually in Asian population, but sometimes people here go to get the acupuncture treatment even when they don't have an Asian background. So now, Jeffrey, you might want to turn it off again here because I'm going to try to back up, and this was the chest CT on that person. Okay, so let me see if I can bring up the next case here.
Now.
Okay, this fellow, so my theme here is things that people do to themselves. So acupuncture is one thing that you can have done to yourself. This fellow was making methamphetamine at home, and evidently one of the chemical reactions can release anhydrous ammonia. And so this man had a toxic inhalation of ammonia. And you can see he's got this ground glass opacity in his right upper lung. There's a lot of breathing motion artifact here. He is not taking a very deep breath, so his airway's fairly collapsed. And then he's got a fair amount of bronchiectasis. There are lots of secretions in these bronchi down here. He probably has some air trapping. So this was an acute phase of this. I think he came in around this time with all of this acute stuff in his right upper lung. And then about a couple of weeks later, he had this follow-up exam. He now has less intense ground glass in the right upper lung, but he has this more widespread mosaicism here. And this is inspiration. And again, he doesn't take a very deep breath, and his expiratory views are not much different from this in terms of the degree of airway collapse. So we don't have a good distinction between inspiration and expiration, but I think that he has got rarefaction of vessels where the lung is relatively black, and I think this reflects air trapping. So lots of, I think, small airways disease, maybe constrictive bronchiolitis even, and then large airways disease, bronchiectasis here. They often go together. The fact that this man on that earlier study already had a lot of airways disease suggests to me that he's had more than one inhalation, or there's more than one thing going on with him. So this is toxic inhalation of ammonia with the production of methamphetamine. Okay, so that's one bad thing that people can do to themselves. And then let me show you this case of a man with cystic fibrosis who has this CT scan, which is pretty typical of his CT scans, with lots of airways disease, both small and large airways disease. The mosaic attenuation reflects the small airways disease, and the bronchiectasis is the large airways disease. And then let me bring up a later study on him. I hope that it will come up here if I do this. Let's see. Okay, well, this is, okay. And this is a later study on him now, at a time when he came in with an exacerbation of his cystic fibrosis symptoms. And so at this point, you can see that if we look at his lung bases compared to that previous exam, he now has all these tiny little dots here, central lobular dots. In the setting of cystic fibrosis, this could represent an acute bronchiolitis. But there are other causes of central lobular dots. And the other thing is, I'm not displaying the earlier image at the same time, but he now has right ventricular dilation and flattening of the septum toward the left ventricle here. So he has pulmonary hypertension. He was much more symptomatic than before, and he has got all these little dots. And with with the MIPS, we see again that it really looks as if these little dots are studying the vessels. And so, based on the CT findings, clinicians went back and talked to this patient again, and he admitted using oxycodone tablets ground up and shooting them in through his intravenous catheter. So he'd probably done this a couple of times before. There had been some episodes around this time when he came in acutely worse. But this was a dramatic change in his right ventricle, and his pulmonary artery is a bit larger than it had been, reflecting the acute pulmonary hypertension that goes with the vascular occlusion from this injection drug abuse. So this is another case of excipient lung. Subsequent CT scans showed resolution of the small central lobular dots and regression of the right ventricular acute dilation and stuff like that. So he's my second patient I've seen that recovers from this. Our pathologist had originally predicted that things would only get worse with this condition, but they can regress. Things can get better. So another case of excipient lung.
Wow.
Okay.
Okay, thanks, David.
Thank you.
Peter, did you have cases?
Yeah, I have a few.
All right, you can go ahead.
You guys see the radiograph?
Good.
Okay, so I was called about this radiograph by one of our anesthesiologists. And so what I see here is just bilateral perihilar consolidations. Looks like pulmonary edema, but no pleural effusions, and the heart size is normal. So he gave me some good history. He said the patient was recently extubated and became very short of breath after extubation. And he asked me if this made sense for negative pressure pulmonary edema, and I thought this was like a very good fit for negative pressure pulmonary edema. Basically, the patient has no heart failure history, and they didn't really get any large amounts of fluid during their surgery. So I thought so that's the diagnosis we came up with. And then after he went back to the floor a couple hours later, the primary team got a CT of the chest because they continued to be short of breath. And so here are the findings on the CT, pretty consistent with what we saw on the radiograph, just bilateral airspace opacities, looks like edema, no pleural effusions, heart size looks normal. And just another pertinent negative here, no endobronchial impaction to suggest that this was aspiration related. So I thought this was a good case of negative pressure pulmonary edema following extubation, likely due to laryngeal spasms, which is one of the more common causes in adults. And I included a good review article I found here. I like this diagram here. It shows the proposed pathophysiology. Basically, you have increased inspiratory effort against the obstructed upper airway, and on the right you can see it generates really high negative pressures in the thoracic cavity, and those get propagated through the pleural spaces into the vascular spaces, and that generates a really high hydrostatic pressure across the capillaries, and you get acute spillage of fluid into the alveolar spaces, and then that correlates with the imaging findings of the acute alveolar edema. And then this is the follow-up radiograph a day later. Looks like most of the edema has resolved.
Yep, very nice example of that.
Okay, so go on to the next case. This is a patient with a history of left-sided breast cancer, had a left lumpectomy, and there's this device here in the left breast, which I had never seen before, and then we spoke with several other members of our group. They'd never seen this before either. This is called a biosorb, and it's a three-dimensional device that has a bioresorbable framework, and then it has these radio-opaque markers centrally, and it basically gets placed post-lumpectomy by the surgeon to mark the excision site for future radiation therapy planning. And then I have a website. This is the website of the company that produces the device, and this is what it looks like. The white material is the bioresorbable framework, and then you have the radio-opaque markers. They come in different sizes.
So the markers stay around just to mark where the lumpectomy is performed, but everything else absorbs?
Exactly.
Huh.
Yeah, the framework should absorb. Have you guys ever seen this before? This is our first.
No.
First time.
Yep.
I can show, and this is what it looks like on the radiograph. So on the radiograph, you just see the 6 markers in the breast. Okay, and then I'll show one last case. So this is a trauma case. Specifically, it's a gunshot injury. I read this about 2 weeks ago. And this is the chest, abdomen, pelvis of the patient, chest, abdomen, pelvis CT, which he got immediately when he got admitted around 9 p.m. And the interesting thing here is the ballistic track. So here's the entry site, exit, and then if we follow the line here, you can see the bullet shattered the spine, large posterior mediastinal hematoma, paravertebral hematoma, and then along the track courses right through the right side of the heart, particularly the region of the tricuspid valve here. More subtle finding is this small thrombus here at the RV apex, right there. And then around exactly this, when he was admitted, he got this echo. And this is the interesting finding on the echo is this image here shows the injury to the tricuspid valve. So the tricuspid valve is completely destroyed, and there's open communication between the RV and right atrium with open regurgitation. So I'll play the loop here. So you can see this large regurgitation through a destroyed tricuspid valve apparatus from the bullet injury. And then what's interesting is that the patient got another follow-up radiograph 2 hours later, so around midnight, and it shows the acute progression of the injuries in the heart. So if we go to the tricuspid valve, which we saw in the echo, now there's this new density, low density surrounding the tricuspid valve, likely thrombus, worsening thrombus here in the RV apex, and new thrombus around the PA valve. And then additional interesting finding I thought is this low attenuation right at the interventricular septum. So I thought this was new compared to the CT from a few hours ago. So I thought this could be acute ischemic injury from injury to the RCA, which would be in line with where the bullet was coursing through, because this basal septum is supplied by the RCA. And then a few other things, just worsening edema in the lungs or fat embolism syndrome from the fractured vertebral bodies, and then the large hematoma.
Do they take him to surgery in between, right?
So these CTs were done the night before, and then they had tried to take him to surgery. I was reading them the following day, and that he didn't make it through the night, but they did try to take him to surgery. And that's all I have.
All right, thank you. I'll just show one case real quickly here, maybe time for two. Let's see. This is a cool case. Let's see here. There we go. So this is a child with tetralogy of Fallot, and I think, Howard, you showed one years ago that Leif had shared with you. The reason the CT was they thought the aorta was abnormal on the echo, and so we see here's the left aortic arch, and then just you can see right here there's a second little communication. So I'll make a sagittal. That shows right here we have a double-barreled aortic arch. So this is a persistent fifth arch associated with tetralogy of Fallot. And so I've only seen it. This is the only other time I've seen this, other than the case from that I think Howard shared years ago. But yeah, very, very rare congenital anomaly. So that fifth arch typically regresses in human embryos, but occasionally can hang around for a while, and you get this double barrel aorta. And then as far as his tetralogy goes, he's got you can see he's got, there's a small perimembranous VSD there. Okay, and I'll quickly show, let's see, this is a nice case too, and this has a neat finding. So this is a 29-year-old female who has hyperparathyroidism, and this is a sestamibi scan. This is the early image. And you can see there's normal salivary gland uptake, there's thyroid uptake, there's uptake here in the chest, and then you'll see there's extensive uptake in the breast tissue. Here is the fused, sorry, this is the CT. Here's the fused SPECT CT, and you can see there's the area in the mediastinum that corresponded to the mediastinal area, and then just extensive uptake in the breast. And so that's not a normal site of uptake, but it turns out she's lactating, and so you can get physiologic uptake of sestamibi and when there's a active lactation, which I think is kind of cool. I'm not seeing that before. And then this is just a classic appearance of these parathyroid adenomas. They look like little lymph nodes, but they're often hypervascular. This one looks like it's in the thymic bed up along the pericardium. Very common location for them, and fairly easy to remove. So, yeah, but I think this was neat primarily from the nuclear medicine standpoint, where you have unusual but physiologic uptake in another organ. All right. And one of the things, one of my colleagues who also does nuclear medicine told me that's why sometimes you'll see sestamibi uptake in breast cancers, where you get the extra glandular growth. They can take up at sestamibi. So it can be picked up occasionally on a cardiac SPECT CT. All right, well, we'll stop. It's 3 o'clock here. We'll resume next week. Thanks, everybody.
Thank you.
Bye, everyone.